All right, so I'm gonna start off for everybody an introduction because not
Okay.
everybody. This is our first time having Dr. Elsendor with us, so I just want to say a welcome to everybody for this topic on just updates from CTOS. For those who don't know, CTOS is a really important meeting that takes place in the sarcoma medical community. It stands for Connective Tissue Oncology Society. It takes place once a year, and all these top sarcoma doctors come from all over the world to participate and learn and network. So Dr. Elsendor will be giving an update on this, but I just want everybody to know that participants are in a listen-only mode. So if you do have questions, because unfortunately the structure of this is now everybody should type in their questions in the Q&A. They can't verbally ask the question, so I will be doing that for them. Everybody should know that the information provided in this seminar is not intended as a substitute for your physician's guidance and care. I think everybody knows me by now as Sarah Rothschild, the Executive Director of the Life Raft Group. I'm going to introduce our speaker today, Dr. Thierry Elsendor. He earned his medical degree at the State University of Haiti and a Master of Science degree at the University of Oxford. He trained in internal medicine and hematology oncology at Yale New Haven Medical Center and Tufts New England Medical Center, respectively. Previously at McGill University, he is now a senior physician and medical oncologist at the Dana-Farber Cancer Institute, affiliated with Harvard Medical School. His interests cover treatment and investigations of sarcomas, including GIST. So I will hand this off to Dr. Elsendor to provide some updates. And in the meantime, feel free to type in your questions in the chat so we can prepare to share that with him at the end of the presentation.
Okay, thank you so much, Sarah. It's a real pleasure and honor to be speaking at the invitation of Life Raft. And I just apologize to Sarah that we currently are experiencing an internet problem. And that's the reason why I'm not able right now to project my slides, although there is one last rescue that I'm going to try, and if that doesn't work, I'm ready to do my talk, without slides, but with all the information. So hold on one second.
No problem.
Okay, unfortunately, that didn't work, but my point was to give you an update on gastrointestinal stromal tumors presented at CTOS, the Connective Tissue Oncology Society 2024 meeting that occurred in San Diego just a few days ago. And I do not have any conflict of interest to disclose for that talk. But I have to say that, obviously the information that I am presenting has been retrieved from the abstracts and the slides from the authors who are presenting that information, and that some sentences may have been quoted verbatim from the abstracts presented. I thought that it would be useful to start with some generalities, even if I know that I'm talking to people who are experienced with the disease, experienced in the management of the disease, people who are advocates for the disease. I think that in order to put the new information in context, it's very useful to have some sort of refresher on the background of this disease. So GIST, or gastrointestinal stromal tumors, are cancers, sarcomas, cancers of the mesenchymal tissues that are believed to derive from cells of the Cajal plexus. The Cajal plexus is basically the pacemaker of the smooth muscles of our stomach and gut. And it's believed that GIST cells derive from those cells. GIST as a spectrum of disease can occur pretty much at any age, but on average, it's a disease of people of middle age and older age. The median age is 65, meaning that half of the patients affected with GIST are older than 65. And as you already know, this is a disease that affects mostly the stomach in 60% of cases and the small bowel in 35% of cases. But of course, we do see patients whose disease originates from other organs, such as the esophagus, the rectum, or even the peritoneal cavity. And given the anatomic location of GIST, they tend to spread essentially to the liver and the abdominal cavity in the peritoneum. Other sites of disease, such as the lungs or the bones, are rarer and typically happen very late in the course of the disease. So, an important aspect of GIST is that it's not truly a single disease, but what I would call a family of related diseases. Because one thing that's very important with GIST is the molecular makeup of the disease that we are dealing with. GIST can be seen in association with mutations of the KIT gene, of the PDGFR alpha gene, and there is also a group of so-called non-mutated KIT and non-mutated PDGFR alpha GIST. By far, the most common types of GIST are caused or are associated by a mutation of the KIT gene. And the primary mutations, meaning that the mutations that are at the origin of the disease, are usually exon 11 and exon 9. This is important to remember as we look at the data of some clinical trials. But as the disease evolves, additional mutations occur, and these mutations that cause resistance to imatinib, which is the typical first line of treatment, can be seen in exons 13 or 14 or exons 17 and 18. And in general, it's considered that GIST associated with KIT mutations, at least at the beginning, is sensitive to imatinib. The second group that is common, so KIT mutations occur in 75 to 80% of cases. The second group, which is GIST associated with PDGFR alpha mutations, occur in 5 to 10% of cases. And they're also variably sensitive to imatinib, with the exception of a rare subtype, the mutation of PDGFR alpha called D842V, which is known to be rather insensitive to imatinib. And then finally, in about 5% of cases, 5 to 10% of cases, we will see a GIST that is diagnosed, but that does not have any mutation of KIT or any mutation of PDGFR alpha. Most of those GIST are called sdh-deficient, meaning that they lack the enzyme SDH in their metabolism, and that can be caused by genetic or epigenetic problems. And much more rarely, there are other mutations such as NF1, BRAF, and TRK that are occasionally associated with GIST. And in general, those rarer types of GIST, those that are not associated with KIT mutation or PDGFR alpha mutation, are not sensitive to imatinib. So the second part of the background that I wanted to cover was the workup of GIST. So as you know, we start with a biopsy. an examination of the biopsy under the microscope by the pathologist, staining by KIT1 and another antigen called DOG1 are considered essential to the diagnosis. And molecular analysis is also recommended from the get-go, as that can have a direct impact on the care, whether we're talking about adjuvant treatment for prevention or relapse, of treatment of established advanced disease. For radiological evaluation, when we need to know whether patients have localized disease or more advanced disease, different types of radiological studies are available, such as endoscopic ultrasound, CT scan, or PET scan, or MRI. Now, we usually have two kinds of clinical situations. Patients will be deemed operable, metastatic, which is typically inoperable, at least up front, and there will be the occasional patient who is somewhere in between. For operable tumors, the standard of care is upfront surgery, and then when the tumor has been removed, the pathologist, after determining what's the size of the tumor, what's the mitotic rate, which is, in other words, the number of cells dividing per field, and the organ of origin, the pathologist will assign a risk level. Is the tumor that has been removed low risk, intermediate risk, or high risk? And there is even a category called a very low risk. We usually recommend adjuvant therapy to pretty much everybody who has high-risk features, and often to patients with an intermediate risk. Patients with low risk and very low risk features do not benefit from adjuvant therapy, but nonetheless will be followed. And there is an ongoing controversy as to what should be the optimal duration of adjuvant treatment for prevention of relapse. We tend to think in a certain way that the longer the better, but the jury is still out for that question. I will finish covering the basics by saying that, fortunately, there has been a lot of progress made in the management of GIST at the metastatic stage. At the beginning, we had imatinib as the only drug. And imatinib, of course, has had a tremendous impact on the natural history of the disease, transforming it from a disease associated with a survival as short as 6 months to a disease where patients live many years. But now, besides imatinib, we also have sunitinib, which is the standard second-line treatment, and after that, drugs such as regorafenib and ripretinib. So let's go to the meat of our webinar, which is the updates brought by CTOS 2024. One poster that I thought was interesting was an analysis of 3,144 case reports of GIST, where the authors focused on identifying underappreciated demographics, underappreciated clinical presentations, and underappreciated biology. So their goal was to describe unusual or neglected aspect of GIST. And for example, they were able to show that GIST, as I said a little bit earlier, can occur in virtually all age ranges. They were able to find that GIST had been described in neonates, infants, and children less than 12 years old. And they were also able to describe that GIST, not unlike other cancers, can be associated with what we call paraneoplastic syndromes, meaning that there are other disease presentations that can accompany the presence of the tumor itself. So for example, hypoglycemia, which is low blood sugars attributable to the presence of the tumor, or hypercalcemia, which is something that we see sometimes in patients with lung cancer, for example. They have been able to show that it was present in some patients with GIST, or low thyroid function. They also describe that in addition to the common sites of metastatic disease that I mentioned, such as liver and peritoneum, that unusual sites occur, such as the bones, the lungs, but even the brain. So I think that, this tells us that we clinical researchers and scientists are often dismissive of case reports. We often consider them as being weak evidence for any medical information, and even more so for any medical treatment. But when those case reports are put together, analyzed together, carefully selected, I think that they bring valuable information and that they can contribute to scientific knowledge. Another such report looked at the rare type of GIST driven by a rare mutation of KIT, of PDGFR alpha, which is D842A, which I mentioned earlier. So D842A is known to sarcoma medical oncologists as being not sensitive to imatinib. So we don't use imatinib as a prevention, and we don't use imatinib as a treatment for metastatic disease. So these authors actually, who are a host from LifeRaft Group, they analyzed their database, and they looked at 941 patients with KIT mutation exon 11, which is the most common type of GIST, and they compared those patients to 62 patients who had a D842V mutation. And what they saw was that overall, if you look at all patients, all comers, all stages confounded, people live more or less the same time, they have the same longevity. And in that group, they had an overall survival that ranged from 17 to 20 years. And there was no statistically significant difference between the two groups. However, as they pointed out, the mechanisms underlying that similar longevity was very different. In what way? First of all, it was more frequent for patients to present with metastatic disease with exon 11 mutation than actually that's a reverse. I put it in the wrong way in my table. So it was more common for patients with exon 11 mutation to present with metastatic disease at onset. That was seen in approximately 30% of cases versus 15% of cases in patients with D842V mutation. Patients with exon 11 mutation, which is the more common of the two, because of the number of medications that are available to treat GIST nowadays, those patients tend to live a much longer time than patients with D842V mutation. On the other hand, patients who present with localized disease and who undergo an operation, it's more common to see patients with what I would say common GIST So KIT11 mutation, it's more common for those patients to have a relapse of their disease than patients with D842 mutation. We talked about the number of medications that are available to treat GIST. And, for exon 11, as I said earlier, we have imatinib, sunitinib, regorafenib, ripretinib, all approved as standard medicines. And for the 842V, the drug that is specifically approved for that mutation is avapritinib. And those patients don't benefit from adjuvant imatinib. There was another study from the French group that looked at what happens to patients with the 842V mutation. Again, those patients are rare. Their natural history is not well known. The optimal way to treat them is not clearly established. Given the rarity, even in a large center such as Lyon, they were able to identify 25 patients retrospectively and 7 patients prospectively. And what they saw was that with avapritinib, which is the drug that is specifically approved for that group of patients, the response rate was 71%. So that's quite encouraging. And in fact, most everyone benefited to some degree, even if there was no a response rate as per standard criteria. The vast majority of patients experienced clinical benefit, at least in terms of stable disease. Even more interestingly, patients who received avapritinib lived significantly longer than those who did not. But I found interesting that in this group of patients with D842V, for whom it's considered that nothing or almost nothing works except avapritinib, they were able to see that other drugs such as imatinib and sunitinib worked in approximately 10% of cases in terms of response rate, and that all the tyrosine kinase inhibitors were entirely inactive with a 0% rate. I mean, I'm mentioning this because this was presented in abstract, but please keep in mind that this abstract has not been peer-reviewed. We don't know whether the response rate reflects our standard criteria, but I think that it's good to know that. Even if this is a kind of GIST subtype that's considered insensitive, maybe after avapritinib, if there is this progression, it's still possible to try one of those 2 tyrosine kinase inhibitors. So my take on those abstracts that looked at the different kinds of GIST, their natural history, is that retrospective analysis, while not considered being as groundbreaking as a prospective clinical trial, they do bring excellent information if they are well analyzed. And I insist to say that the molecular profiling of GIST is very crucial at diagnosis. It has a direct impact on the natural history of the disease. It helps to predict the prognosis, and it does have treatment implications. So I think that everybody diagnosed with a GIST should have their tumor analyzed for a molecular profile. Any questions at this point, or should I continue?
Anybody has any questions, feel free to type it in the Q&A. Thank you for providing an overview for now, and also some of the poster summaries, including the LifeRaf groups. Much appreciated.
Okay, so I'll move on to what was presented for localized disease. So there was a study that's also a very practical clinical problem. Sometimes we see patients with a localized gist, but they're so sick or they have such a poor general condition that the surgeon or the anesthesiologist hesitates to take them to the operating room. And one thing that we do commonly is to put those patients on imatinib, because as far as cancer medicines are concerned, imatinib is considered to have a low toxicity profile. But how much good do we do to those patients? We don't have much information about that. And that retrospective study looked at a large database and 12 patients aged between 69 and 86 were retrieved from the database. Those patients, 7 men, 5 women, had a localized gist and were not operated because their medical history included problems such as heart failure, coronary artery disease, advanced emphysema, etc. And 9 of them, their disease came from the stomach. 2 had disease localized in the duodenum, which is the beginning of the small bowel. And 1 patient had disease localized in the esophagus. Those 12 patients who were considered post-surgical candidates were given imatinib. And 3 years after starting treatment, 90% of them, which was 11 patients, their disease had not progressed and they were alive. The 12th patient died from metastasis of another cancer. So she did not die from GIST. She died from metastatic breast cancer. And the latest imaging that was performed before she passed showed that the tumor had remained unchanged in size and appearance. So, I mean, granted, 12 patients, maybe not much, to provide guidelines. But I would say that as a clinician, that if I have a patient who cannot have surgery for localized GIST, I feel that I have some evidence to continue my practice, which is to administer imatinib, which seems to be able to control the disease for a measurable amount of time. Now, as you can imagine, most of the clinical research that happens in the realm of GIST is about advanced or metastatic disease. That's where most of the research goes, because the course of localized disease has been pretty much charted. We had an update on a study, the INTRIGUE study. So just to remind people, so the INTRIGUE study compared patients whose disease had progressed on imatinib. Those patients were randomized between sunitinib, the standard of care, and ripretinib, which is currently approved essentially in the 4th line of treatment. Because of the relatively high activity of ripretinib and the durable benefit afforded by ripretinib in the 3rd and 4th line, investigators try to see whether ripretinib could substitute for sunitinib in the 2nd line right after progression on imatinib. And unfortunately, as we know, that trial was overall negative, ripretinib having not been shown to be superior to sunitinib in terms of overall survival. But there were hints that maybe patients who had secondary mutations in exon 17 or 18 might benefit more from ripretinib than from sunitinib. And those data were presented at an ESMO symposium earlier this year. So those same investigators, they presented an update at CTOS, and they reminded us that patients were randomized 1-to-1. In other words, 50% of the patients, after their disease progressed on imatinib, 50% were assigned to ripretinib and 50% to sunitinib. And the endpoint was to look at the overall survival in the whole group, but also specifically, they looked at those who had a mutation of exon 11. And what was very innovative is that they looked at circulating DNA. So by looking at blood tests, looking for DNA shed from the tumor, they made the assessment of the genomic makeup, the genetic makeup of those tumors. What they found was that 53 patients out of 362 had mutations of exon 11 plus a mutation of exon 17 or of exon 18. And basically, 27 patients got randomized to ripretinib and 25 patients got randomized to sunitinib. So again, it's a subset analysis. It's a group from a larger group. So patients with KIT11 mutations and who on top of KIT11 mutations had either mutation of exon 17 or mutation of exon 18. And they looked at how outcomes differed when those patients got either ripretinib or sunitinib. And what they saw was that there were fewer severe adverse events with ripretinib, and that the overall survival tended to favor those who were taking ripretinib. They found that those who were taking sunitinib had a median survival of 17.5 months, whereas it had not been reached in those who were taking ripretinib. Now, what does that mean? It means that although overall, when you look at the overall population, all comers with all kinds of mutations, there did not seem to be any difference between the two drugs. We suspect that ripretinib might be more efficacious in that specific subgroup of patients with exon 11 mutations who also have a mutation of exon 17 or 18, and that justifies the ongoing clinical trial that we have open right now at the Dana-Farber and other centers, where patients whose disease has progressed on imatinib, they get randomized to either drug if we find by circulating tumor DNA that they have a mutation of exon 17 or 18. I think that trial is absolutely justified. Another interesting trial that was presented looked at a new KIT inhibitor. So when we look at the medications that are available for GIST, imatinib is a specific KIT PDFR alpha inhibitor. But drugs such as sunitinib or regorafenib are not specific. And for that reason, because they hit multiple targets, they are associated with multiple side effects. The trial that I'm going to present came with a new KIT inhibitor, a medication with a code name of IDRX42. And IDRX is a selective KIT inhibitor. And the second thing that is interesting about it is that it inhibits not only exon 9 and 11, which are responsible for the primary mutations, but also exons 13 and 17, which are secondary mutations involved in the resistance to imatinib. So that was an early phase trial, and that trial looked at different groups of patients patients with GIST with no prior treatment. So they had not even received imatinib yet. They got started off with IDRX-42. Another group was patients whose disease had progressed after imatinib only. So instead of getting sunitinib, which would have been the standard of care, they received IDRX-42. And then there were patients with more advanced disease and who were more heavily pretreated. And unfortunately, I'm not able to project the table, but what we see is that there was an interesting response rate observed in all groups of patients. If I looked at all 66 patients who were presented, the response rate was 23%. And as you can imagine, a higher response rate was seen in second-line patients, those whose disease had progressed after imatinib only. They had a 48% response rate. But even patients in third or fourth line had a response rate ranging between 20 and 25%. The medication seemed to be well tolerated. Most patients had some sort of clinical benefit defined as either an actual response or disease stabilization. And also, very interestingly, patients who responded or whose disease remained stable on IDRX-42, they had prolonged progression-free survival going beyond 9 months. And since this is an ongoing trial, the information keeps coming. And that also justifies a clinical trial that aims to compare sunitinib to IDRX-42 in second line. Now, a third trial that I want to present, it looks at a rarely used strategy. As you know, we don't often use immunotherapy in terms of checkpoint inhibitors in the management of GIST, although there is some evidence that GIST also has an immune microenvironment. So there was a clinical trial that was presented where patients with GIST were given a combination of avelumab, which is an anti-PD-L1 inhibitor, and that is approved especially in the management of genitourinary malignancies. And those patients received a combination of avelumab and axitinib. Axitinib is a tyrosine kinase inhibitor that also hits multiple targets, and that is not often used in the management of GIST. That trial came, I think, from a single center, 56 patients, most of whom had received at least 3 lines of treatment. So that means that they were a group of patients heavily pretreated. A group of patients with a disease more refractory. 81% of those patients had a mutation with the KIT gene, and 3.4% had a mutation with the PDGFR alpha gene. And interestingly, more than 15% of those patients had no mutation in KIT or PDGFR alpha. And this is a very special group of GIST that's treated very differently. Usually those patients do not receive imatinib. They tend to be treated with more advanced tyrosine kinase inhibitors. And very often those patients are not included in modern clinical trials with the other groups of GIST. So what did they see? They saw that 9% of those patients had a response to axitinib in combination with avelumab, but stable disease was observed in 60% of patients. Those who responded had a median duration of response of 1.5 years, which is very encouraging considering that those patients had very advanced and refractory disease. But on average, the progression-free survival, meaning the time that the disease remains stable or responding, was 4.5 months. And the numbers were too small for formal comparison, but the authors suggest that those who had GIST not associated with a mutation of KIT or PDGFR alpha might benefit the most from this combined approach of tyrosine kinase inhibitor plus immunotherapy. But I would argue that those patients often have a disease that is clinically less aggressive, more indolent than the other types of GIST. Now, sometimes we run out of systemic treatment options for patients, but the patients still have a good performance status. Their disease is localized to the liver. And even if they are not operable, we look at liver-directed procedures as a way to help these patients. And one such way is radioactive embolization, which is commonly performed, although there are not a lot of data as to how effective that approach is. And I did find at the CTOS meeting a poster, actually annual presentation, describing the results of radioembolization with yttrium-90, which is basically radioactive beads that are injected in the hepatic artery. So that study was limited to patients with sdh-deficient GIST. So again, sdh-deficient GIST is the most common type of that rare subtype of GIST that does not express, that does not have mutations of KIT or of PDGFR alpha. So this is not a very common group of patients, and the authors presented data on 8 patients who were treated in their centers. And what they saw was that 6 out of 8 patients, so 75% of patients, did have a response, so tumor shrinkage in the liver. The 2 other patients, even if their tumor did not shrink significantly, their disease did not progress further. So in other words, all 8 patients benefited to some degree. And even if at some point the disease worsened, interestingly, there was no disease worsening in the segments of the liver that were treated with disease embolization. So that's something to think about when patients don't have many options, but have disease that's very symptomatic in the liver or that's limited to the liver. So this is about what I have. I'm sorry about the technical failure that we have experienced, but I think that CTOS 2024 was interesting for the GIST community in that it brought new information about rare GIST subtypes that we don't hear much about, new information about potential new lines of treatment down the line, and hopefully in a not too distant future, and also information about some interventional procedures that are performed here and there, but we didn't have necessarily a lot of data. So those data are encouraging and telling us that we seem to be doing the right thing. Unfortunately, there was not much new information about adjuvant treatment. For example, patients who have had surgery. We do know, as I said earlier, that patients who have high risk or intermediate risk situations benefit from adjuvant treatment with imatinib. But for how long should they be treated? You know, we know that 3 years is, we know that 1 year is better than nothing. 3 years is better than 1 year. Now we have data from Europe suggesting that 6 years is better than 3 years. What about lifetime? So I wish we had some more information about that. We also don't have much information about what's the right way to prevent a GIST relapse in patients who have imatinib-insensitive disease. We have no data about that. And I think that, we also struggle in the clinic with neoadjuvant approaches. Patients who have a disease that's not immediately operable, that might be operable, but difficult to operate, we often give those patients imatinib to begin with good success, but it would have been nice to see some long-term data about that. So I'll stop here and we take questions. Thank you.
We do have some questions I want to make sure we get to before the end, because we only have 5 minutes left. And I just want to see if we can at least address some of the questions that came in. So a couple were related to sdh-deficient GIST. So I know you did allude a little bit to that, if there was anything to highlight that really stood out at CTOS regarding the sdh mutation. And also I'll stop there and then I ask the second question after that.
Yeah, so for sdh mutation, I just showed, that study with Yttrium-90.
Right.
There was no update of the trial that was presented last year with a fibroblast growth receptor inhibitor that showed a promising response rate.
Right.
That disease, so there was no update about that trial. And regarding ctDNA testing,
right. So the question is about ctDNA testing, which it may be considered not as developed or fine-tuned enough for GIST, but is there does this signal change in the utility or accuracy of ctDNA for GIST?
Yeah, that's a very good question. So in general, we don't consider that technology to be widespread enough or sensitive enough to recommend its routine use. But the clinical trial that's using it is using a technological platform that's believed to be very sensitive. But I think that we need to see the data to see how good.
Right, more data.
Yeah.
Okay, I'm gonna have this be the last question. Do we track diet or lifestyle to any of these treatments?
So some studies, not all, do look at quality of life, endpoints. In general, they tend to be presented separately. And, and we often have the complete information in the full-length publication. So I don't have any additional information. I'd like to add something, a point that Sarah made, which was a great debate that occurred indeed regarding the overall strategy in GIST, because GIST tends to develop resistance. So should we treat patients in a stepwise fashion? So imatinib and then another tyrosine kinase inhibitor and then another one? Or should we have a more shotgun approach? And the slides of the presenters are not available, but I did participate to that debate. And I would say that, scientifically, on a conceptual level, one can imagine that it would make sense to hit as many targets as possible in one shot, especially if the medication you're going to use is well tolerated. But we have not had yet any evidence that works better than a stepwise fashion, especially in terms of what will be ultimately the most important endpoint, which is overall survival.
Yeah.
Downside to having more than one surgery to remove tumors? I don't think so, as long as the tumor is operable and that the patient is able to withstand the operation and that the operation makes sense from an oncological standpoint.
Yeah. Okay. I just want to thank you to everybody today for being so patient with us and listening for the entirety of this talk and getting these good nuggets of information about what was shared and presented at the CTOS conference last week. But I also want to thank Dr. Alcindor for his time and preparing this.
Thank you very much for having me, and thank you for listening.
Thank you. Be well, everyone.